Assalamu alaikum and good afternoon, everyone. My name is Dr. Syed Wasif Ali Shah, and I'm working as Associate Professor and Head of Orthopedic Department, Shaikh Zayed Hospital, Lahore. Before I start my presentation, I would like to say many thanks to the organizers for inviting me for this occasion and speech. And I would also like to congratulate the organizers uh, to organize and to conduct this sort of conference in the era of pandemic and corona. And it is not an easy job, I tell you, to conduct and to actually make this event a success in this background of pandemic. It's a difficult job and they've done it. So I congratulate Professor Tafazal, Dr. Aflaq, Dr. Adnan, and all of the team, those who have put a lot of efforts to make this event a success. My today's talk is about a topic which is actually a topic of mutual interest between the rheumatologist and orthopedic surgeons, and that is about the necrosis of the femoral head, or you may call it an avascular necrosis of the femoral head. In my talk, I would like to have an overview that what we are going to discuss. Actually, this topic is so common and it is so important that everybody actually knows much about it, but still we will try to recapitulate and try to refresh our knowledge with whatever we can. Okay, in this talk, we'll like to have an introduction, epidemiology, clinical signs and symptoms, how do we stage the avascular necrosis, how do we diagnose it, and then of course the treatment options, either medical or surgical, and what recent advances do we have, and what we can have a take-home message at the end. Avascular necrosis, also known as the osteonecrosis, as the name implicates, it's basically a problem with the vascularity of the femoral head, which results in the necrosis. Now, how and why this vascularity is compromised, this is what this jingle is all about. The vascularity, whenever is compromised due to any reason, it is going to cause the necrosis of the femoral head, and it is going to cause the trouble. And then, of course, then the sequence of events, it is there. Why does it happen? We will discuss in detail about the pathophysiology of it in the forthcoming slides. And before going into it, what is the epidemiological evidences which we do have? It is seen in 20,000 of the new cases per year in the United States, although we don't have any data of the local Pakistan, but this is how we can calculate that what is the burden of the disease, because it accounts for about 10% of all the total hip replacements which we see for any of the disease of the hip. The total hip due to avascular necrosis is about 10%. Males are affected a bit more as compared to female due to an obvious reason of having more exposures to the trauma and more having a sort of medications, self-medications and Hakim medications. Average age at presentation is about 35 to 50. It's a middle age problem most of the times. And more importantly, the location. It is to be noted that in 80% of the cases, the disease is bilateral. So for the rheumatologist and for the physicians also, this is important to note that whenever a disease is seen in one side, in 80% chances there that you may have a disease on the opposite side. So always get an X-ray of the pelvis AP with both hip joints. So there could be a multifocal origin of the osteonecrosis as well. Less number in 3%, but you may have osteonecrosis at the same time on the other parts of the body, like humeral head, like talus, and like some other bony, like the femoral and the tibial condyles as well. So that can be seen, but in less number of the cases. What are different risk factors? Before I go to the direct causes, I would like to elaborate some indirect causes. Most important and the most frequently seen, the cause of the avascular necrosis in our setups is basically the steroids, which are used, of course, and for rheumatology, we know it has been used in abundant amounts, but The self-medications, the heme medications, it also is the reason that why people have got this problem. And steroids, or either they are endogenous or exogenous, they can cause this problem. Why and how, we will discuss later on. Alcoholics, hypercoagulable states, and then systemic lupus erythematosus. Transplant patients, because they have to use lot much steroids again. Some viral infestations, protease inhibitors type of the HIV medications, and idiopathic, of course, when you don't find any reasons. The direct causes could be a trauma. That is most of the times is the reason. Fracture neck of the femur, fixed, but it never works, and it leads to the avascular necrosis. Hematological disorders like leukemia, lymphoma, dysbaric disorders, marrow replacement diseases like Gaucher's disease, sickle cell disease, and irradiations, of course. How does it happen? If you can see this slide, you may see that in around the neck of the femur, there is a network of vessels. And from the neck, you can see the vessels, they are going into the head. 80% of the supply of the head is from this network, and 20% from the opposite side of the head, you can see through the ligamentum teres. So something if goes wrong on the femoral neck side, there are 80% chances of impairment of the supply. So the most often cited risk factors are corticoid administration and alcohol intake. And how do the corticoid administration induces the avascular necrosis? There are different theories about it. And one of the theory is the vasoconstriction that leads to an increase of procoagulant factor production. And the other theory is that it also increases the adipogenesis. It decreases osteogenesis and downregulates osseous repair and remodeling through fatty embolic phenomena. Pathology within the hip joints generally involves a varying degree of the articular cartilage loss secondary to the inflammatory process. This loss usually involves the entire femoral head, resulting in the concentric loss of the cartilage and subsequent concentric joint space narrowing. There may also be varying amount of the bone loss and even the femoral head collapse. And of course, there could be a varying degree of the cyst formation. And in about 5% of the patient, there is a significant protrusio acetabulum. In the head, it is going and rubbing the acetabulum, it is going into the pelvis a bit, but in lesser number of the cases. So there are different theories that we can summarize it again. Steroid-induced osteonecrosis of the femoral head due to lipid metabolic disorders, decreased osteogenesis, and potentially an insufficient blood supply, cell adipocytosis, and gene polymorphism. Various reports have concluded that cortisone may be described as an independent variable, especially in high doses, and that it increases the risk of osteonecrosis up to 20 times. So this is something to be noted. Then how do we stage it? ARCO International Classification of Osteonecrosis is the one which is generally accepted amongst all the orthopedicians, and consensus is there that this staging actually provides a sufficient knowledge that at what stage the patient is going to present and at what stage the patient is actually there to have its treatment options. And before going to understand of this whole of the table, I would like to see you on the next. The ARCO staging system have been modified. Initially, if you can see again, the staging system was from 0 to 4, but now the modification has been there, which has made it more easy, and the staging has gone from 0 to 6. How we will see that. The first stage is stage 0. Actually, that stage is a stage in which there are no symptoms. Actually, the investigations are normal, but patients do have avascular necrosis. How? Because if you do the biopsies, you may see there is an osteonecrosis. So actually, the stage 0 is the stage which are potentially at risk patients. those patients who are taking steroids, those patients who have got a trauma, they are asymptomatic, they don't have any symptoms. The investigations, again, they are normal, but still there are chances they can get avascular necrosis. So that stage is said to be the stage 0. Stage 1, again, when you see on the x-rays, they are normal, they are bit of the symptoms. And if you can see the MRI and bone scan, these are those things which are positive. What do you see on MRI and what do you see in bone scan, we will see in the forthcoming slides. But again, the x-rays, they look normal, there is no change as such. The head, its shape, its its translucency is all okay, but MRI and bone scan, they are only positive if they are done at stage. Stage 2 is the stage when the x-rays and MRI, they can show the early signs of AVN. There is no distortion of the shape and there is no crescent sign, but there is more amount of osteosclerosis right in the head, which you can see like in the slide. But as such, the shape of the head is normal. As such, there is no change in the shape. There is no crescent sign, but there is some amount of sclerosis, which you can see with the naked eye on the x-rays. So the first change on x-rays seen is at stage 2. And it is sub-classified according to the involvement of the articular surface. If it is like less than 15%, it is stage 2A. If it is 15 to 30%, it is stage 2B. And if it is like more than 30%, it is stage 2C. And this is what you call as quantitation, as Orko has mentioned. Stage 3, very important thing, which we see most often and which we even see written in different types, is the crescent sign. And what is that crescent sign? It is basically a fracture under the cartilage, which causes the cartilage to be a bit down and forms site of a crescent shape, as you can see right in the top of the dome of the head. And due to the damage of the cartilage, this is called as the crescent sign. But you can see the sphericity of the head is again maintained. It has not changed a bit, but there is only a sign which you can see. And if you can see that sign, we call it stage 3. We see this, the disease is being more advanced, but as such, the head has not been D-shaped yet. Again, it is subclassified according to the area of the involvement. And if the crescent sign is involving only the 30% of the area, 15%, it is A. 15 to 30%, it is B. And if it is like more than 30%, it is C. I'm sorry. No, the stage 4 is the no, the shape of the head starts changing. There is signs of flattening and collapse of the femoral head. And again, it is sub-quantified according to the area of the involvement, A, B, and C, less than 15%, 15 to 30%, and more than 30%. But stage 4 is the stage when the shape of the head actually is changed. It is going to lose its sphericity and it is flattened a bit. It is stage 4. Stage 5 is all the changes which we have all mentioned, plus there is a concentric reduction in the joint space. As you can see in the picture, the joint space is all gone. There is change in the head, and the articular damage is also there, and there are early signs of the secondary osteoarthritis. Stage 6 is even more advanced, when there are changes which have been discussed so far, all along with the marked destruction of the articular surface, even on the contralateral side, on the acetabular side, and there are advanced osteoarthritic changes. How the patient presents? Patient presents with the insidious onset of pain. He says that he has got pain while climbing up the stairs, when he is going to sit on the ground, when he is running, when he's jumping. and the pain is more on the anterior side of the hip joint. On physical examination, it is mostly superficially, and on examination of the inspection, it is all normal. But on movements, you may say there are some degree of limitation of movements, particularly the internal rotation. Internal rotation is the first movement to go and the first movement to be compromised when you examine with even the early signs of the arthritis and early signs of the avascular necrosis. How and what do we see on the X-ray? It is actually this only the X-ray changes, which you can see initially normal up to 3 months. When the disease has set in and 3 months times have elapsed, there are hardly any changes. That's what you call as stage 1. The stage of sclerosis that you can see on the most left side of your pictures is the sclerosis. This is stage 2. The head maintains its sphericity. It is looking almost the same, but the sclerosis is there. It looks more white as compared to the normal side. Then there is subchondral collapse, and there is a crescent sign, as you can see in the middle of the picture of the X-rays. This is what you call as the crescent sign, subchondral radiolucent line. More advancing on the right side, there is flattening, and there is change of the sphericity of the head. It has gone more flattened as compared to the more spherical surface, and collapse of the cortex is all there. And then it is, if it is more advanced, of course, then there are changes in the hip joint, secondary arthritic changes, they prevail. How and what changes are there on CT scan? CT scan is again a modality which is used to diagnose and to see the amount of the avascular necrosis. It is used to assess the extent of the disease and calcification. And it clearly shows the articular deformities, which are at times missed on the X-rays. Calcification and bone collapse. And how do we see that a sclerosis is the central sclerosis in femoral head, and it produces an asterisk sign like a star, as you can see right in the center of the femoral head. Then MRI. MRI is that diagnosis is actually the modality of the choice, because it can pick the changes even before the X-rays, and it is 90% sensitive, and it reduces a subchondral, and there is a reduced subchondral intensity on T1, representing boundary between the necrotic and the reactive bone, as you can see. Low signals on T1 and high signals on T2, reactive zones. It is diagnostic of MRI findings. And of course, as I have mentioned, the changes can be detected as earlier as even before. The X-rays, they show any change. Then bone scan, donut sign, like the donut. I mean, there is a central reduced uptake with surrounding rim of increased uptake. It is more sensitive than plain films in early AVN, but it is less sensitive as compared to MRI. Necrotic zone surrounded by a reactive new bone formation, as you can see right on the picture. Now, the management. How are we going to manage this avascular necrosis? It all depends upon the stage at which the patient is presenting and at what time the patient is going to see the advice from a medical professional. Now, if the patient is presented earlier, like in stage 1 and 2, the treatment is bisphosphonates, which prevent further collapse, unloading osteotomies, medullary decompression, plus bone grafting. We will see each and every later on. And if intermediate stages, they're like 3 and 4, we can talk about realignment osteotomies, we can talk about decompressions, we can talk about arthrodesis. And if the patient is presenting in very late stage, like in 5 and 6, the better option is arthroplasty. Although we can have some analgesias and activity modifications, we can talk about arthrodesis, but the best option in the later stages is arthroplasty. The conservative management is focused on offloading the affected joints with the use of crutches. We ask the patient to limit the mobility. We give them analgesias, and we can offer and we can try bisphosphonates to delay the femoral head collapse. Statins in patients on high dose of corticosteroids reduced lipid deposition. Now, bisphosphonates and statins. Uh, I think I will leave on to the rheumatologist to comment on this. The role of the bisphosphonates and the role of the statins. People do use, because in the early stages, of course, we are not going to intervene in that early times. Uh, at least something is done, and that is done with the bisphosphonates. And of course, the results they're fairly good. I must say they produce a fairly good results when they are given in a particular and in selective patients. And of course, statins again, they can give a better results if they are tried in a better early stages. When we talk about the surgical procedures in early or maybe in the middle stages like 3 and 4, or maybe up to maybe in the stage 2 as well, the best option which we consider is the core decompression. And what is that core decompression? What is that procedure? Core decompression means that we create a hole starting from the greater trough, and we go deep up to the area where there is aseptic necrosis, and we ream this whole of the area with a thick sort of a reamer of about 6.5 to 8 millimeters. And it is indicated in ARCO 1 and 2, 8 to 10 millimeter anterolateral core of bone filled with the bone graft, which ideally is a vascularized bone graft taken from either, most of the times from the fibula, and the anastomosis is done with the femoral circumflex arteries, and it is a vascularized graft. And before putting this fibular graft, there is some cancellous chips which are put there right under the dome of the head to lift it up. And in the results, they are very good if done properly and in a proper stage. Decompression of the medullary canal, it reduces pain. And cortical bone, it is actually an osteoconductive sort of in implant, you can say it's an osteoconductive sort of a biological substance which is there. And the cancellous bone is actually an osteoinductive sort of implant, otherwise you can say. Vascularized graft may reverse the necrosis as well. Now, does it really work, and how much effective it is? It depends on a lot many things. I mean, it depends upon how much expertise do you have, and how much particular and how much experience do you have to have this vascularized site of graft. And in comparison with the vascularized graft, there are theories and there are studies in which you can say, they say that if you can make only a hole and put it and pack it with the non-vascularized fibular graft, can produce almost the similar results as compared to the vascularized grafts. There are studies which say that the results are not that much good, but it is all controversial and an academic discussion. But in general consensus, if the fibula is vascularized, it produces a good result and better results. Then we can have a realignment osteotomies. And what are those osteotomies? Realignment osteotomy means that the area of the femoral head, which in a way that the non-involved area comes under the dome of the acetabulum. This is what all its basic principle is. It is indicated in ARCO 3 and 4. It is used to relocate the necrotic area from weight-bearing portion of the femoral head. It has got and the angular osteotomies are said to be more common. Multiple techniques for holding the fixation. And it is intertrochanteric rotational osteotomy that is more oftenly practiced, but technically it's more demanding and has got a higher success rate. Theoretically speaking, and on pictorial, it looks very good that you're going to rotate something which has been involved and you're getting something which is not involved underneath the dome of the acetabulum. But you see, it is a double-edged sword. On one hand, you are going to do something to realign that area which has not been involved. Okay. But you see, this process, if it goes on, and later on you need a total hip replacement, which is there at times, most of the times actually we do need it, then you're going to lose a chance of decent total hip replacement because actually you're changing the whole of the anatomy of this area. So that is the reason that these realignment osteotomies, they look good on the pictures and on papers, but practically speaking, they had never been popularized. And also because they are very challenging and very much demanding. And of course, then later on, the chance of a decent total hip is also lost. Arthroplasty, it is the indications are younger patients with crescent sign or more advanced femoral collapses and plus minus acetabular degenerative diseases. Patient, if it has got an irreversible etiology due to the chronic use of steroids, patients who are older than 40 years with large lesions, they are good candidate for arthroplasties. In young patients with AVN, there is a high rate of linear wear of the polyethylene liner and high rate of osteolysis than compared to the older patients who have total hip arthroplasties post osteoarthritis. Provides good pain relief and functions, most reliable means to provide pain relief and immediate return of function. Actually, total hip replacement is an ultimate procedure when every other thing have all been exhausted. Then of course we do have an option of changing whole of the things which have been involved on either side. Uh, Total hip replacement is one of the most commonly performed and successful operation in orthopedics as defined by the clinical outcomes and implant survivorship. When do we recommend total hip? Hip pain that limits everyday activity such as walking or bending, hip pain that continues while resting, either day or night, stiffness in the hip that limits the ability to move or lift the leg, inadequate pain relief from anti-inflammatory drugs, physical therapy, or walking supports. Preoperative optimization of the patients who are planned to go under the total hip arthroplasty is critical. If we can improve the if we can improve the outcome of the procedure, optimization includes medical optimization, perioperative counseling, and then of course the prophylaxis with DVT, with anesthesia plans and pain management plans. Preoperative counseling is really important because then you have to tell the patients that this procedure is a procedure which is an elite procedure. You're going to have a change of your whole of the joint, but even after when you have got, the change of the joint is there, you will not be able to perform all those activities which are you going to do with the normal hip joints, like running, like jogging, like it will be difficult for you to sit on the ground. You better have to use a chair which is at least 2 feet high, like dining chair. So you have to change your lifestyle and you have to modify your living accordingly. So this is what you call as the perioperative plannings. THA implants, actually the implants which are being used nowadays, these are modular sort of implants in which you got a lot much modularity. Modularity in a sense that you have got an option of putting a stem which is either cemented or a non-cemented. We have got a femoral head which is of different sizes. We can have a change of the length of the neck with this femoral head. We can go with a large, medium, and a small neck. We can have a different sizes of acetabular cups. We can have a different different sort of liners which are there to be used in the acetabular cup. So it is much more modular and you've got many choices. The cemented implants are used most of the times in elderly patients, which are more than 65 years of age. They are, and those who have got low demand, they are better, fixed, and their chances of loosening are late. And you can straight ahead ask the patient to be mobilized because the stem has already been fixed with the cement, and you don't need to go and wait for the ingrowth of the bone, and they are said to be more stable. The cementless implants are chosen for the younger patients with more activities, but you have to protect weight bearing for at least 6 weeks of the time. But it has got a longevity which is better than the cemented implants. So whenever possible, now the things are switching towards the cementless side. We will talk about in the forthcoming slides. Of course, there are many complications. Like every procedure, risk and complications are there. Those similar to associated with other all joint replacements. They can include infection, embolism, dislocation, limb length inequality, loosening, impingement, osteolysis, metal sensitivity, nerve palsies, chronic pain, and so on. There are many. Results of hip arthroplasty in rheumatoid. Minimum 10 years results of cementless total hip arthroplasty in patients with the rheumatoid arthritis. This is in the study which I have shown here. Implant survival at 17 years were 99.5% for stem and 93.9% for the cups and 90.8% for the liners. So it's a pretty good and a decent amount of the percentage with implant survivals on either side. But you can say the more stable side is the stem size as compared to the established side. And it has been seen that the failure rate is more towards the established side as compared to the stem. And that's why we will see that most of the times nowadays, the things are actually switching towards the cementless side, but still there are people who advocate to use a hybrid sort of implants. They say on the femoral side, put the cement, on the established side, just go with the cementless sort of implant to avoid this sort of, failure as it has been shown this. Among the liners used, THAs with highly cross-linked polyethylene showed better survival compared with those with the conventional polyethylenes and aluminum-bearing surfaces. The patient survival rate was 36.9% at 17 years after total hip arthroplasties. Multivariate analysis exhibited that older age at operation and greater dose of concomitant corticosteroid resulted in shorter patient survivals. And what are the trends of the total arthroplasty in rheumatoid? And have the annual trends of the total arthroplasty in rheumatoid arthritis patients decreased? That was the question. And this study has shown the annual rate of THA among RA patients showed only slight increase between 2002 and 2013. So with the use of disease modifying anti-rheumatic drugs, uh, it decreased both the disease progression and joint destruction. And DMRs are now often utilized as the primary treatment, as you know it much better than me. However, patients may be more likely to be opt for surgical management, given the advances in operative techniques as well as the peri and the post-operative courses. So, what is rapidly destructive COXARTHROSIS of the hip joint? It is a rare syndrome that involves rapid and total deterioration of both the acetabular and the femoral aspects of the hip joint. RDC is an idiopathic condition with no single diagnosis, laboratory, pathological, or radiological finding. THA have been used as a treatment modality for the severe RDC with good response in respect to reviews of total hip arthroplasties performed on patients with RDC. Recent trends. As we have talked about the core decompression, instead of going with a big hole of 8 mm. Now the people are switching towards something in which they create actually many small holes of 3.2 mm drills. And it is said that by creating many holes, actually the decompression is better and we can address different areas of necrosis as compared to hitting with a single large opening. And people are saying that it is much better as compared to the conventional way of decompression. Total hyparthroplasty, as you can say, I've talked a bit initially as well. We are switching towards the cementless side with increased modularity and modification in bearing surfaces. Now I would like to show you some of the clinical cases. The first case was a young girl with the AVN and the stage 4 AVN of the right hip joint. Core decompression was performed, and you can see a hole right in the middle of the femoral head. Second case with the 45 years old female with AVN of the left hip. You can see the destruction of the joint. It is stage 5 or maybe 6. Left-sided hybrid sort of total hip has been performed, and you can see the acetabular side is cementless, while the femoral side has been a cemented sort of an implant. 36 years old male with advanced AVN with the bilateral secondary arthritic changes due to the steroid intake. You can see here cementless arthroplasty has been performed. You can see the cup, it has been fixed with the screws, and then the femoral stem. 40 years old female with right-sided AVN of the hip, and again right-sided hybrid total hip arthroplasty has been performed. You can see the cement in the femoral side, and you can see the acetabular side has been fixed with the screws and it is non-cemented. So the hip joint is less frequently affected in adults in rheumatoid arthritis than other joints. However, involvement may result in disabling symptoms and significant diminishment of the function. Once femoral head collapses more than 2 mm, or if the secondary degenerative hip conservation procedures become ineffective and arthroplasty remains the only better option. Total hip arthroplasty, if performed at right time and with the right technique, has excellent results in improving the quality of the life of the patients. And with this, we'll stop. And if there are any relevant questions, I'm there to answer, sir. Thank you very much.